Hello, everyone. Welcome to the TAA's National Conference, Tic-Con25. We are so glad that you have joined us. Before we begin, I want to introduce myself. I'm Elizabeth Newlin, the Director of Program Operations here at the TAA, and I will be moderating this session on navigating life with OCD and Tourette syndrome, challenges and care strategies, presented by Jossie Sevilla and Dr. Erica Greenberg. Please locate the Q&A at the panel on the bottom of your screen. During this presentation, please put all questions in the Q&A. You are welcome to put questions in anytime during this session. The chat is not open to attendees, just the Q&A. I also wanted to inform you that closed captioning is available for this session. You can turn on closed captioning by clicking on Show Captions at the bottom of your Zoom screen. Now, I would like to introduce our speakers for this session. Jossie Sevilla is a social worker in the mental health field. Jossie has TS and was diagnosed officially when she was 21 years old. Jossie is a TAA Rising Leader and Education Volunteer, as well as a camp counselor at Camp Twitch and Shout, and she enjoys getting involved in the Tourette community. Dr. Erica Greenberg is a board-certified child and adolescent psychiatrist and the director of the Pediatric Psychiatry OCD and Tic Disorders program at Massachusetts General Hospital. She is an assistant professor in psychiatry at Harvard Medical School and a co-director of the Tourette Association of America MGH Center of Excellence. Dr. Greenberg graduated from Weill Cornell Medical College with Alpha Omega Alpha honors, and she completed her general psychiatry residency at Harvard Longwood Psychiatry and her child adolescent fellowship training at MGH McLean, where she served as chief resident in both programs. Now I will turn it over to Jossie and Dr. Greenberg to begin their presentation.
Thank you so much, Elizabeth or Betsy, and happy to be here today presenting with Jossie. And so what we're going to do is I'm going to talk first for about probably 10, 15 minutes or so, and then turn it over to Jossie. And then at the end, we'd be happy to answer any questions. And so we're talking about navigating life with OCD and Tourette syndrome, challenges and care strategies. In terms of disclosures, I'm on the medical advisory board of the TAA and now the scientific advisory board of the Trichotillomania Learning Center, TLC. I receive honoraria for talks, but I don't have any conflicts of interest. And so since this is a Tourette, Tic-Con, I thought I would start by just describing some of the basics of OCD, even though I imagine a lot of people in the audience are aware. But so OCD is a condition characterized by obsessions and or compulsions. Obsessions are unwanted, repetitive, intrusive ideas, thoughts, images, urges, impulses that cause significant distress, anxiety, or discomfort, different from a fixation, which we often hear, I'm obsessed with Legos or something. That's not the way we define it in OCD, and that's, you have more of a positive feeling towards it. In OCD, the obsessions are unwanted. And then the compulsions are the behaviors that one feels as though they must do. It could be mental, physical, to get rid of the unwanted feelings, often driven by the obsession, or secondary to rigid rules or other factors, which I'll speak about soon. And in general, the compulsions are not connected in a realistic way to the obsession. So it's that's how we think of them. In terms of diagnosing OCD, it has to take at least an hour a day and or cause distress and impairment in daily functioning. So a lot of people will have obsessive compulsive symptoms, but it doesn't count as OCD unless they additionally meet that criteria. And so in terms of the characteristics, it often has a bimodal onset, meaning that it two peaks of when it onsets. So the first is around 8 to 12, which is the pediatric or early onset. More often females a little bit later than males. And then the second one is in the late teens, early adulthood, which is the adult onset. In the early onset, it's about 2 to 3% prevalence. And there was a great study a number of years ago that looked at just in general the prevalence of obsessive compulsive symptoms in the community. And this was looking at youth in the Philadelphia area. And what they found is up to 40% of individuals, again, will endorse having some OC symptoms. But when you use those other criteria, only 2 to 3% meet for actual OCD. In general, in OCD, symptoms wax and wane, so come and go, ebb and flow, sometimes for obvious reasons, like in periods of stress, other times not necessarily. And it tends to frequently be a chronic condition, although treatment can be and is very, very effective. And so, regarding in particular the early onset OCD, it's about a 3 to 2 ratio, males to females, greater likelihood of co-occurring conditions, which I'll speak about. And also compared to the adult onset OCD, it has more heritability and more of a genetic component, so more likely to have it if you have it in the family. And regarding specific OCD symptoms, they're often factored into these different subgroups. So these include contamination or cleaning, which is the one people often think about, although that's just one of the subgroups. Um, Another subgroup is symmetry. And so that includes things like ordering, counting, writing, rewriting, reading, rereading, and often needing things to feel just right, or trying to eliminate sense of incompleteness. The other category is forbidden thoughts, which is often broken down into taboo thoughts, and then also into doubt and checking. So did I do this? I'm not sure if I did this. What if this is going to happen? I don't know. And in some circles, OCD has been referred to as the doubting disease. And a lot of these forbidden thoughts are often, like more hot button themes. So aggression, sexual, religious, could also be somatic, like body related, is it cancer, et cetera, et cetera. But what's also really important to know is that it's not just anxiety that is associated with the obsession that can drive compulsions. So yes, it's true. So sometimes, in a lot of cases, obsessions are fear-based, and so one has to do a compulsion in order to, quote, stop something bad from happening. Wash your hands to make sure you don't get sick, tap something 3 times to make sure, a loved one doesn't die. But also there's other feeling states that can precede compulsions. And so that includes disgust. That's often highly kind of represented in the OCD population, incompleteness, or this feeling of not just right. And then one also always has to pay attention to whether there's avoidance, because if one is avoiding the factors that might trigger the obsessions or compulsions, you're not going to see them, but that doesn't mean it's not still there. And again, the audience that we're speaking with know this, but in Tourette syndrome, co-occurring conditions is the rule, not the exception. And so about 85% of individuals with Tourette will have at least one co-occurring condition, with OCD and ADHD being the two most common. With, the numbers vary a little bit, but OCD about 50%, ADHD about 50%, both together 30%, one or the other 70%. But also, one is more likely to have mood, non-anxiety OCD, oppositional defiant disorder, rage attacks or intermittent explosive disorder, symptoms of, if not full criteria for autism spectrum disorder, and then also body focused repetitive behaviors like trichotillomania or skin picking, learning disorders, executive dysfunction, sensory hypersensitivity. Doesn't mean one has to have all of these, and all of these are on a spectrum in and of itself, but these are the ones that, at least genetically and et cetera, we know are related. And so I always like to touch on why we see these sets of conditions together. And it's because many of these co-occurring conditions are associated with the same disrupted neural circuitry. So this circuitry, this cortical, striatal, thalamocortical circuitry, is associated with habit formation, affect regulation, reward processing, and inhibitory control. And so when it's disrupted, you see disinhibition and dysregulation of emotion, motor, like tics, cognitive, which could be more the OCD and motivation-based processes. And a lot of individuals that have this circuitry that's disrupted have challenges with impulsivity, which is basically inability to stop oneself from pursuing something positive. So I know I really want it, I shouldn't do it, but I can't stop myself, or more in that direction. And then also challenges with compulsivity, which is the opposite, which is inability to stop oneself from removing a negative. My hands feel sticky. I need to wash them to get rid of that negative feeling. And so basically, with all of this together, you end up seeing these clinical manifestations all from the same, again, disrupted circuitry. So tics, OCD, ADHD, executive dysfunction, not necessarily mood disorders, but mood dysregulation. So very feeling strongly, quick up, quick down, and the BFRBs. There's also certain neurocognitive profiles, at least anecdotally, also somewhat in the literature, that are commonly associated with individuals that have Tourette and OCD and some of these related conditions. So one that can come up is a cognitive inflexibility. Difficulty sort of changing one's thinking or behavior in the face of new or changing information or environmental feedback. This is where we often will talk about more black and white thinking or rigidity or stuckness. And again, there can certainly be symptoms of ASD, autism spectrum, in there, but also this could even be without necessarily having autism spectrum disorder. And particularly more likely to see this when the person is heightened, more anxious, distressed, etc. Often we hear, an over-exaggerated sense of justice or fairness, um, sometimes at the expense of, social niceties or norms, which can be tricky for kids, can lead to sometimes peer exclusion. But the other factor that we often see is what I was mentioning a moment ago, which is this intensity and quickness to feel. And so oftentimes, what I'll say is, the person literally feels strongly, and it could be any emotion, anger, sadness, happiness, but very, 0 to 100 is often what parents will describe, or individual, adults as well will, even if they don't necessarily express it, so that others can see, they might still feel that internally. And then a final like word we often use, particularly in those with OCD, is having sticky brains. Anecdotally, a lot of the individuals I work with have really strong memories, and so something gets in there and it sticks, which can be good and bad. And so focusing in on the overlap between tic disorders and OCD. So as I mentioned, in Tourette, but 50%, 30 to 60 meet criteria for OCD. And this is again compared to about 2% in the general population. And in OCD, about 30% will meet criteria for chronic tics or Tourette, particularly those with the early onset. And again, this is in like 2 to 3% of the general population. And multiple studies over the years have shown genetic linkage between Tourette and OCD. So, in the past, it was even said, are these, two sides of the same coin? As I just mentioned, they both have that shared circuitry. We also know that certain classic OCD symptoms are more clinically and genetically associated with a Tourette diagnosis. And so this is that incompleteness, the symmetry, just right category, touching, tapping, rubbing, ordering, reordering, and then also the intrusive harm thoughts. And so what's also been shown is that people with OCD will sometimes report these aggressive urges or obsessive aggressive urges to, what if I harm that person? I have an urge to harm them. I don't want to do it, but it's in my head. That was shown that it has genetic linkages with Tourette, OCD, and ADHD. And in general, there's some thinking that tic-related OCD, which I'll speak a little bit more about in a moment, is more associated even with tic disorders, the Tourette process versus the OCD without tics. And again, as I mentioned, the tic-related OCD is more heritable than OCD without tics. As I'm mentioning, in terms of OCD, we think that there's different genetic risk factors for having OCD without tics and OCD with tics. And so this leads to the question, does it matter? Does tic-related OCD differ from OCD without tics? And the answer is yes. And so, as I mentioned, It's often tic-related OCD, or those with Tourette and OCD, often associated with particular symptoms. And so that's often, again, the symmetry and those forbidden thoughts, particularly symmetry, aggressive intrusive thoughts, sexual intrusive thoughts, religious intrusive thoughts, and then again, this checking, touching, writing, rewriting, evening up symmetry, and this not just right factor. And again, as I've mentioned, it's more common in those with the early onset OCD versus the adult onset. And so the term Tourettic OCD was originally coined by Charlie Mansueto back in 2005. It can sometimes, I think, be confusing. That's a project that Charlie and I and others are working on, which is cool. Can be confusing because that term right now can refer to either the broader set of symptoms that someone with both Tourette or chronic tic disorders and OCD experiences, or a specific tic-like or a compulsive symptom. But either way, what they found is that it's associated with male sex, earlier OCD age of onset, more OCD impairment, early sensory hypersensitivity, attentional difficulties, learning difficulties, impulsivity, BFRBs, and anxiety and depressive symptoms. And so if you remember back what I was describing here, a lot of this is that same shared conditions based on the shared neurocircuitry. So there's a reason that, it sort of makes sense. And what Charlie and his co-author originally described too, is that it's highly driven by these not just right feelings, where individuals were more or often describe a more sensory phenomenon or a feeling of incompleteness driving their compulsive symptoms versus a fear-based thought. They'll often describe as well having to compulsively perform certain tics until they feel just right, which is, we think of a little bit more in that OCD group. And what they often say, and I've heard this so many times from the patients I work with, I'm not afraid something bad is going to happen. I'm afraid if I don't do it, I'm going to explode. So again, not fear-driven, but more discomfort-driven. And so in terms of differentiating, does it matter? And so first, just briefly to do a quick overview of tic treatment, which again, I imagine many people here know. So behaviorally, we have CBIT, which can be very effective. But in terms of pharmacology, the only FDA-approved medications we have are haloperidol, pimozide, aripiprazole. We also, even though those are the only FDA-approved ones, first-line treatment is always or often the alpha agonists, clonidine, guanfacine, with those in the atypical antipsychotic category being second line, third tier, those in the typical antipsychotic, but essentially the treatments for tics pharmacologically are alpha agonists and antidopaminergic or antipsychotic, even though it's not psychosis agents. And then in terms of OCD, the treatment overview, the first line or the behavioral treatment, which is very effective, is exposure response prevention, a form of CBT. And then medications, the gold standard is selective serotonin reuptake inhibitors, SSRIs, fluoxetine, sertraline, fluvoxamine, clomipramine, which is a tricyclic antidepressant, but also very serotonergic. And then also citalopram, duloxetine, so serotonergic agents. And what we know is that for those with OCD that have co-occurring tics, it might impact that treatment. And so differentiating between these, does it matter from the from the psychiatry pharmacological perspective? Yes, because if it's compulsions, you're using serotonergic agents. If it's tics, you're using alpha agonists, antipsychotic agents. And so if it's both together or Tourettic OCD, one may need the combination of both OCD targeting and tic targeting treatment. In terms of behavioral therapy, it's obviously hard to use, fear-based hierarchical exposures if the symptom isn't driven by fear. And so there's, I think, more anecdotally, but some research being done, practices to incorporate more like dialectical behavioral therapy or acceptance commitment therapy components where you're adding in more distress tolerance techniques versus exposure to fear. And so the other reason, as I sort of touched on, that it's important to know what to think about this combination is that the presence of tics may impact the effectiveness of SSRI treatment. And so this landmark study, POTS, Pediatric OCD Treatment Study back in 2004, looked at treating youth with OCD with SSRIs therapy, the combination, or placebo. And they found that SSRIs were certainly very effective in treating OCD. However, when they looked at the group that had OCD and co-occurring tics, sertraline didn't actually outperform placebo. Both got better to a degree, but it wasn't significantly better. Um, and so, if someone does have OCD and we're thinking of medication management, it's still always important to start with SSRIs. But, there's some thinking that perhaps this Tourettic OCD or tic-related OCD might not be as benefited from standard OCD treatments. And so at that point, one can consider augmenting with additional medications. The ones that have the most evidence are, again, the antipsychotics, the dopamine blocking agents, which makes sense because, as we were just talking about, that's what's commonly used in Tourette syndrome. But also, one could always try, again, if we're thinking pharmacologically, something like the alpha agonists, guanfacine, clonidine. And so, how does one differentiate between OCD compulsive symptoms, tic-related tics? The more I do it, the actually more gray I really do think it is. As a quick rule of thumb, what can be helpful is to ask oneself, what's driving this behavior? Is it more of a thought, anxiety, like obsession, which is more than associated with a compulsion, or is it more of a feeling sensation that's unpleasant, more like a premonitory urge that leads to a tic? But again, not uncommonly, it's something in the middle. So a patient I learned coined the term ticulsion, which is where you might have more of an intrusive thought or anxiety that might drive a tic-like movement. And then what I've been talking about for more so is the Tourettic compulsions. So when you have these compulsions driven by the sensory or not just right, non-anxiety based feeling, and or feeling like when one is doing a tic, having to do it repeatedly until it feels just right. And a takeaway too is that whether it's a tic, a compulsion, an impulse, they're still all more likely to be seen in individuals with Tourette syndrome, given that shared circuitry and the vulnerabilities. And so I kind of like this as a quick takeaway slide. So compulsions, they temporarily relieve the distress caused by the obsession. So you might tap your forehead to alleviate fear of dying. Tics temporarily relieve the distress caused by premonitory urge, more stereotyped or repeated in nature. So tapping forehead because of an uncomfortable feeling on one's forehead. Impulse, failure to inhibit goal-directed behavior that's motivated by reward. So tapping start before one's supposed to in a race. And then the only other category I didn't talk as much about, but is important too, and is seen in the in individuals with these combos of condition is disinhibition, and that's more so failure to inhibit, regardless of the consequence. It's not necessarily motivated by reward. It's truly more acting without thinking. So tapping the button in a hallway because it was there. And so with that, I'll end and pass along to Jossie.
Hi everyone. So a lot of the things on my slides are things that Dr. Greenberg just shared. So I have some repeat things in here, but I will reiterate. And a lot of what I'm going to be sharing is related to my own experiences. So with that said, I know Dr. Greenberg had mentioned the 30 to 60% of those with tics also having tic-related OCD. There's also many other conditions that can co-occur with Tourette's, as she mentioned. Um, a couple takeaways that I think are very important for anybody to know, or anybody who's experienced this, or anyone who loves somebody who experiences this, is that tic-related OCD is a spectrum. It waxes and wanes, and tic-related OCD poses challenges that tend to overlap with other health conditions. Dr. Greenberg, thank you. So, Tourette OCD is a subtype of OCD occurring in those with tics. It is not an independently classified diagnosis in the DSM. The difference between TOCD and OCD, like Dr. Greenberg said, is the trigger being a physical urge. And there's also the overlap where it could also be a triggering thought. So I know that ERP was mentioned in CBIT and CBT, but another combination of treatments could possibly be ART in combination with CBIT, and I know Dr. Greenberg also mentioned DBT. So there's lots of different options when it comes to figuring out what works best for each individual. And I know Dr. Greenberg went into great detail about the medications. So those treatments are usually in combinations for anxiety, OCD, and tics all at once. And now I'm going to tell you a little bit more about my experience because it's different for everyone. So some people may have the urge to perform tics a certain way in order to satisfy an urge. My tics are often numerical, and I tend to do all of my tics in sets of 3 and 5. I also like a couple higher numbers. So when I get into that just right feeling, I tend to go to those same higher numbers, and it can be problematic. So my tics are huge with the just right feeling and the evening up. And a lot of my tics can be due to fears, but if they're not done a specific way, I don't feel any physical relief. Like what Dr. Greenberg had mentioned about the thought causing a compulsion or like the discomfort feeling and it manifesting itself in my tics. Go ahead. Thank you. So here's some treatment options. I know that ERP, exposure response prevention, was one that Dr. Greenberg had mentioned. So, exposing myself to triggers and learning to tolerate uncomfortability and not allowing myself to perform compulsions. I've been doing ERP probably since I was about 16, and doing these exposures has allowed me to take these things that are incredibly distressing to me and incredibly triggering and forcing myself to be uncomfortable until I'm able to changed my way of thinking because some of the distressing thoughts that I have are so far away from the truth. Like, there's no possible way that they could happen, but it's still something that is triggering for me. So, allowing myself to feel it, but also challenge myself to not do the compulsions related to those obsessions. And then ART, which I mentioned earlier, the goal to shift out of automatic responses. This was it's still a huge thing I'm working on. So I have an example. My tic where I grab water bottles and squeeze them 3 times. And the practices that I worked on for OCD have helped me break my automatic pattern so that it doesn't feel nearly as much of a need. It's more of like something that I can let go of without performing over and over. Go ahead. So, coping with Tourette OCD. This one's a tough one. So, there's some management strategies that have helped me be able to manage intrusive thoughts, compulsions, and tics because they all coexist together. A couple of the things that help me, I am physically active all the time. I love to do any sort of physical activity. During those activities, I may still struggle with obsessive counting and I may still have tics and they may still cause a disruption, but they're also not nearly as distressing. So the compulsions become easier for me to manage when I'm doing activities that I really like. So I'm a dancer, I love to dance, and that's like my time when I feel like I can focus on something and my brain is not obsessing over everything else that could possibly be going on. Like I allow myself the space when I dance to only do that. And I think that it's incredibly important for me. And I definitely encourage finding those skills that work for you, those activities, those places that you can be that help you with that. And in addition, I like to do art, reading, and writing, and anything where I like to focus on a specific goal helps me manage both my tics and my OCD. So, TOCD, it can be extremely dangerous, at least for me. I know that there's other people that it affects them less physically, but for me, it's a huge physical manifestation. I've broken my hand 7 times, actually. I've broken it again since I made the slide. Um, I have these tics, so the obsessive count that I have in my head when doing these different tic-related compulsions, I have these numbers listed here, 73, 100, 150. Sometimes I have some other numbers that I pick. Um, and I have broken my hand and punched walls, doors, shower tiles over 100 times. And something that I think is important for people to understand is that it hurts a lot, but it does not stop. So that was always something that I think people in my life couldn't quite understand, that if it hurt me so bad, why am I still doing it? Because the physical need is still there, regardless of if my hand is purple. So I had to keep going. And then after all the pain, I often replicate the feeling on the other side of my body. And it's distressing, but it's honestly one of the things that makes me feel the most helpless. Like I'm not able to be in control of my own body. And it's really one of those things that if I were able to not do it, if I were able to do something different and be different in the situation, I would. But I've not been able to successfully do that at this time. Next slide, please. So I want to instill hope because I do believe that I will get better. A lot of my skills have helped me in many different situations, especially in public. But I have not yet successfully been able to stop in the middle of a rage tic or in the middle of a compulsion because if I don't finish it, then it doesn't feel right. It doesn't go away. The urge doesn't stop. But I have found ways to redirect myself, and I found the coping skills that help me. I keep myself busy all the time. There's really not any waking hour where I'm not doing something of some sort, even if it's just something around the house. I don't just do nothing because that leads to a lot of thinking and a lot of obsessing and a lot of room for me to struggle with different tics and struggle with different obsessions. So I tend to struggle and I know that I can't prevent it, but learning how to understand myself and accommodate myself has been the most important part about trying all these strategies I can in order to help myself get better. Since I can't prevent it, I've tried to satisfy the urge another way. I've tried to use my CBIT strategies, and while I haven't had an immense amount of success, I do think that I will get better. And I think the more that I understand myself and my triggers will help me continue to work towards these things. I'm like on a huge waxing phase right now. I have really intense symptoms in a lot of my areas because I mean, I have Tourette's, OCD, and then many other conditions. So with my chronic health, struggling to prevent these issues is not really something that has been able to be successful for me. But the more I understand about myself, for example, if my OCD and rage together trigger these tics, it's gets worse because I physically harm myself. I've, like I said, broken my bones. I've gotten concussions. I've broken my stuff. I've broken other people's stuff. There's holes in my walls. Like these things in my life are troubling, but I don't believe that it will always be as hard as it is right this second. So I think since I have a lot of knowledge, it will help me to find ways that I can be better in that day and really just take it day by day. Next slide, please. So, how I feel about this part of my story. So, I need to take this part of my life situation by situation. Sometimes it's really minute to minute. There are some times where it's best to let myself have these tics, if even if they go on a specific way or for a specific amount of time, and it causes me less distress and issues if I just do them, because then if I do them, I will feel some relief for a period of time. And then other times it causes me more trouble and more pain to continue to let tics happen. And I've struggled for a long time with the acceptance of my TOCD and several other of the subtypes of OCD that I struggle with because it makes me feel so out of control. And one of the things about autonomy and shame is like the lack of being able to control different parts of my life when I feel like I should be able to control them. It's debilitating. I feel shame all the time, and learning to accept that this is something that I deal with and have been dealing with for a long time is hard because there really isn't something that has made it quote unquote better or go away. So, learning to accommodate myself is what I've come from that. Being able to accommodate myself and know my own window of tolerance when it comes to my OCD related tics, it's been key in helping myself be successful in different parts of my life. I really struggled for many years. I didn't have a job when I was a bit younger, like when I was like in college. I didn't have a job right away because I was struggling so much with my tics and OCD to the point that I was not feeling well enough to leave my house and do the things that I want to do with my life. So the accommodations that I've put in place for myself have allowed me to do the things that I want to do. And now I have a job. Now I do extracurriculars. I do all kinds of fun things. And I think that that's important because otherwise, what's the point? I didn't know before what my story was going to become. But if I didn't do something I could that I can do, which is give myself as much accommodation and grace as possible, I wasn't going to ever be able to succeed in the things that I have now succeeded in. Next slide, please. And support. I think that this is probably one of the most important parts of this whole journey that I have been on. I was diagnosed with OCD when I was 16, so and I had symptoms much younger than that. Same with Tourette's. I wasn't diagnosed until I was an adult, but I have found the most support in surrounding myself with people who understand my situation. So building a support system is huge in my recovery and my understanding of who I am, and having support is crucial. Anybody, regardless of what they're dealing with, humans need a support system. So I have friends who know when I have repetitive tics that they can be dangerous at times. They know how they can support me if needed. They know how certain tics manifest themselves, and it's something that I've been able to communicate in advance. I can communicate with my support system for when I need anything. And an experience with OCD that has been important for my support system is knowing how deeply rooted survival responses are in my TOCD. So, since a lot of my triggers are related to thoughts and feelings of fear, and some are simply related to urges, knowing the root of what's going on has been so important. So, the people who have taken the time to understand that part of my life have been it's been life-changing in its own way. I'm grateful for the people who have decided that they will be my support system and that they want to understand, they want to help where they can. And it's a struggle. I want to be able to do all the things like everyone else. Independence and autonomy is a huge desire, but there are often barriers. And I struggle to move on when tics are not done right because something may happen, something negative may happen. And whether that be a compulsion and tic related struggle, it also can just be something rooted in fear and anxiety. So when I better understand why things are happening and why my brain functions the way that it is, it helps me understand and it helps me communicate how others can help me. It's really been so important, and I'm grateful for the people who have taken the time to understand and support where they can. All right, go ahead. And that is the conclusion of my part.
Thank you so much. Thank you, Jossie and Dr. Greenberg, for that amazing presentation. I'm going to start reading through the questions in our Q&A for our presenters to begin answering. Um, Let me see. If you could take some time to complete our session survey, which is accessible through the QR code on the screen. We appreciate your feedback. As always, this helps us plan future programs here at the TAA. Okay, so I'm going to go ahead and get the questions pulled up. All right, so we have one comment here. This isn't a question, but I have such relief reading the note on the slide under autism co-occurring and being hard to diagnose because it's confounded by tics and OCD, because I keep coming across trying to support situations where no one knows where the symptoms are coming from. So it keeps being hard to get symptom relief. All right, I'm really curious about a balance with Tourettic OCD situation if the environment feels not right, but the other executive dysfunction means that keeping the environment clean enough to be able to cook, do physical therapies, they establish systems in the house. The systems are developed with an OT to account for pain and other capacity limiting factors. If there are life circumstances that force the person to abandon the systems and they aren't allowed for weeks to make it right, the dishes are never all the way done, the counters are never all the way clean, etc. Could this instigate a crisis? How do you support someone in a situation like this? It looks like their OCD needs support, but do we help them get through the system so they're working again, or do we try to help them get through the extreme discomfort and dysfunction some other way?
I can let Jossie, I don't know if Jossie, you want to take this one to start. And
Sorry, I'm trying to break down the question. I have a couple answers. So it was current lim wait, sorry. Elizabeth, can you read that last part one more time? I lost the question.
Yeah, absolutely. It's
Oh wait, I
could
found
this
it.
instigate a crisis? How do you support someone in a situation like this? It looks like their OCD needs support, but do we help them get through the system so they're working again, or do we try to help them get through the extreme discomfort and dysfunction some other way?
I think that that is entirely an individual's perspective because I can speak for myself and in the terms of if the dishes are never all the way right or the counters are never all the way clean, could it instigate a crisis? Absolutely. I will rage over things like that. But in order to support somebody, it really depends on each individual. Like for me, if I'm in that state, I need reassurance. I need calm. I need somebody to be an example of the the person who is there. I want them to understand, first of all, but I want them to be an example of someone who wants to see things from a different perspective, wants to see things better for me. Because yes, in my crisis state, I'm not seeing how things will be better. I'm not seeing how I'm going to manage the situation, and it takes a long time often for me to get out of that state. So, supporting someone in that situation for me looks like knowing in advance if something were to arise, what strategies and skills and support looks helpful for me at that time. So if somebody were to come up to me when I'm in a crisis and I were to be having an excessive amount of tics or whatever it may be, I think that if they came up to me and were rude and yelled at me and degraded me and invalidated me, that's never going to be something that is useful. But support looks different in every situation for every person. So if somebody's OCD looks like it needs support, I would encourage somebody in that situation to ask if there are some things that they can do to support them, because if you want them to be working again, help them get through the extreme discomfort, that is likely something that needs to be communicated, and they may be open to communicating that, but sometimes I don't even know. Like when somebody asks me if there's ways that they can help, I may not know. So having those conversations in advance has been extremely helpful for me, because once somebody is in a state of crisis, it's basically means that all the part of the brain that is able to control logical thinking is completely blocked off, and I have no access to my coping skills. So the in-person and in advanced situations for support has been probably the best option. And like I said, that's different for every person. I hope this answered your question.
Yeah, I have nothing to add. I think that was incredibly well said, and to the point of, the need for the individual, the proactive planning, like when you're in a crisis, not being able to access. So, you're not going to do much learning in the setting of a crisis. But yeah,
Yeah.
I super awesome answer.
Thank you.
Can you share your view of the current limitations in DSM-5 TR regarding obsessive compulsive disorder with tic-related specifier and Tourette's disorder? I have Tourette's disorder and OCD without tic specifier diagnoses. I always knew they overlapped, but the descriptions of the Tourettic OCD here fit my experience exactly, which feels exciting. Feels like a parallel to the AUDHD movement for people who have ADHD and autism spectrum disorder.
Yeah, I can comment on that a little bit. I think it's a great point and a great question. And take this with a grain of salt, unofficial, but I don't like the DSM oftentimes in general, in terms of the diagnoses, particularly for youth, because a lot of these are so intertwined. But what the DSM does is it really tries to put things into boxes that don't actually fit cleanly into boxes. And so at least, a lot of the clinicians that I work with that I know will talk about, yes, like if you're seeing someone, you ultimately might give them a diagnosis, but what's really more important is what the actual experience is. Because again, I personally don't think that the DSM captures it well. OCD with tic specifier is in one category, tic disorders are another category. They're all especially early onset OCD, or neurodevelopmental conditions that kind of, weave into one another. And so it's easy for me to say, but I sort of not ignore the DSM, but I would take a lot of it with a grain of salt, because it's meant to organize things that don't always have a clean organization.
Okay, thank you so much. Let's get to the next question here. Question for Jossie. Do you have to feel the pain as part of your OCD, or can you satisfy the tic OCD by punching something less harmful, such as a pillow or wearing padded gloves?
So yes, the pain is essential in the completion of certain ticks. I have tried all the strategies. I literally have a punching bag in the corner over here. I have boxing gloves. I've tried punching at things that are softer, but it does not. I could punch a pillow for 8 hours straight and it will still be the same. So, unfortunately, I have not found the best solution, if there is a solution, to the less severe of like the Tourette's tick count and like the obsession related to those ticks and being able to keep myself out of harm's way. I do my best, but being able to redirect those ticks because the feeling of pain is necessary. You're right. I am unable to always find a way to make it less destructive, which honestly, in a lot of those situations, I can't even think straight. I'm just doing. I'm not even able to comprehend what I'm doing a lot of the times. I'm just doing it. And yeah, it's a really frustrating feeling. But yes, that is the pain is an integral part of those ticks, which is how I've broken my hand 7 times.
Okay, and then I have another question here. How do friends and family help support you in the moment? What are things they can do?
Friends and family help support me in the moment. I am one of those people where I like to be near people. I like to have people nearby. I like to have support, but I pretty much need someone to just exist with me. I need to figure it out for myself. Every single time that somebody else is near when this happens, because honestly, a lot of times my rage and my like obsessive tick counts get really bad when I'm at home. But if I'm somewhere else and other people are around, I need them to just be present. I need them to be comforting and supportive and give me reassurance because if you're not going to do those things, don't even approach me. I have definitely had instances where people have tried to tell me how I need to handle my life better and like I need to figure it out. I need to stop behaving poorly and stuff. And like it's one of those things that people don't always quite understand that it's a disability, it's not a choice. And for the purposes of support, I really just want people to be present, sit with me, exist with me, and whether they have something to say or not, it's okay. I think that the most important thing for me is just having other people around while I figure it out for myself.
Thank you. I know we have a few more questions. Um, Let me see here. There was one. Is OCD chronic? Can it disappear like TS in adolescence or lessen in intensity? My son has had TS with OCD since he was 12. He is now 15, and we both have improved.
Yeah, yes. That's something I'm interested in, and I think a lot of us are interested in terms of who is more likely for the symptoms to continue versus likely to improve. But I think, again, not researched, so I can't say this for sure, but I certainly have seen a number of individuals that have more of the Tourette's OCD um, improve as they get older alongside the tics. It's certainly not always the case. I think sometimes what kind of goes back to like these symptoms being at the interface. So the ones that like the symmetry, evening up, tapping, touching, that might be more tic related if we are to sort them out. As tics get better, it's possible that those get better alongside it. So even though they're in the OCD category because they're more tick-like, you see that improvement versus those that might be more um, other ones, fear-based, not just right. You might not improve, but we know that pediatric onset OCD in general has a slightly better prognosis than adult onset in terms of those that improve. That said, it's often, with treatment, ERP, medication, but there has to be some percent that naturally improve because we know that the rates of OCD are around 2 to 3% across the lifetime. And so if you have an adult onset group, obviously some from that early group have to improve in order for that number to be consistent. So I think it's an active area of research of trying to understand who might be in what group and not everyone, which is frustrating, but wouldn't lose hope that it's a possibility.
Okay, how would you explain this to possibly a judgmental family member? My 7-year-old experiences mood dysregulation, highs and lows, disinhibition, and impulse control due to his Tourette's OCD, and we have family members who just do not understand.
I got this one. I got this one. Okay. So, explaining to judgmental family members. What I have done to people who have not been understanding of me and my situation has been to bombard them with facts and resources, to make it so that there's so much information put in front of them that when they review it, they can understand, wait, these are proven conditions, these are proven facts. And so when they choose to make judgments in people who just don't understand, often I've had success in once I provided them with facts. I know the TAA has cards and like business like cards that you can hand out, and so that when people are around tics and the co-occurring conditions with Tourette's, they can see like, oh, this is a condition. This is not bad behavior. This is not something that I should be judging. This is this person's life. And I've had pretty good success in people who don't quite understand and allowing them to ask questions to me, allowing them to see that I'm open about what is going on because I found that getting people to understand my world and why things happen the way they do for me, they have to first understand the roots of it. And once they understand that, it helps me to better communicate with these people so that way there's hopefully less struggle in the communication barrier and people are more understanding and accepting when they have the information.
I think that's so well said, and I totally agree. And, especially when I can send an article to a parent about, like, Dr. Budman's work on rage and how it's mostly directed at the mother, mostly at home, all of these factors, and that it feels so consistent. The other thing I sometimes will add, and maybe it gets a little facetious, but, something like, do you think that he's enjoying this? Or basically pointing out that even though the individual is is dysregulated, is in a place that negative things are happening, this is not fun for them. They don't want to be doing this either. Everyone is losing. And so kind of introducing that side, like, no one here is happy. Of course he doesn't want to be doing this. So you can judge, but that's like, what does that help? That's not fair, to the situation. So just kind of reflecting that back. This is not enjoyable, and in fact, he's suffering or she's suffering, too.
Okay, thank you. So thank you all so much for your questions. This has been an incredible discussion. Thank you so much for completing our session survey. Dr. Greenberg, would you mind navigating to the next slide? Thank you so much. We are excited to announce that next year's Tic-Con will take place in Nashville, Tennessee. Save the dates, June 12th through 14th, 2026. We look forward to seeing you there in person. Okay, and then could you navigate to the next one? Thank you so much. Support from our community continues to make Tic-Con25 and other programs possible. Please consider making a gift to the Tourette Association of America so we can continue to provide quality programming for our constituents. We appreciate you. And that last slide, please. Thank you. We encourage you to explore the conference site between sessions and during breaks, including the lounge area, which offers additional resources like our impact survey, take action letter, social media wall, welcome videos from celebrities in the community, and more. Please also take some time to visit the exhibit hall where you can browse resources and chat with our sponsors. You can also join the competition to secure a top spot on the leaderboard and win exclusive TAA merchandise package. Click on the leaderboard tab in the main menu to start completing tasks and earning points. Thanks again for attending this session, and we hope you enjoy your weekend at Tic-Con. Thank you so much, everyone.